pathologies now, and so let's begin. Most of the pathologies that I'll be discussing will be an overlap with Dr. Mahesh Prakash sir's presentation, because nerve pathologies remain the same. What changes is the site of entrapments, right? So whenever you will never get a patient or a request saying that please scan all the nerves of the upper limb. It's not going to be like that. You will usually get a request of one nerve, and most often you will get which particular area to look at. They will tell you whether they are suspecting a radial nerve injury at the level of the wrist, or at the level of the elbow, or in the arm. Plus, if you have a post-operative history, like how we've discussed, if there is a mid-shaft, humeral mid-shaft fracture, then you know that you have to look in the arm, because the radial nerve will be most likely entrapped there, okay? So, in order to identify any nerve pathology, be it an MRI, be it an ultrasound, there are two ways. One is where you know directly that which nerve you are supposed to look for, or sometimes it is when you see a particular muscle atrophy or you see muscle edema. Like for example, if there is a supinator muscle edema, which is like a denervation edema, you know that you want to look for a posterior interosseous nerve in the arcade of Froissart, where it will be entrapped. So a direct is where you identify the nerve pathology by imaging the nerve, and then you look for the muscle. So you always, whenever there is a nerve injury or a nerve tumor, you have to look at the muscles that are being supplied by that nerve. The muscle denervation changes can be acute, which is nothing but edema, which may not be shown up so well on an ultrasound, but you can see it on an MRI. Or it will be fatty infiltration and muscle atrophy, which will be seen on ultrasound as well. Okay. In the indirect one, you first identify the muscle changes, and then you identify which nerve is supplying that muscle, what level will be where those muscles will be affected, and then you start scanning the nerve to identify where exactly in the path of the nerve the pathology is located. So this is just to tell you the normal nerve anatomy. Any nerve has a sheath which is called as the epinudium, which inside the nerve there are multiple nerve fibers which you see hypoechoic. So the nerve, if you've seen the nerve on ultrasound, we see an echogenic structure with hypoechoic dots inside it. So these are the hypoechoic dots which is covered by the perinudium. And then inside these perinudium you have axons which are covered by the endonudium. Now if you see, there is a lot of fat between these nerve fibers, and this yellow color thing, that is fat. Now because you have fat inside the nerve, between those hypoechoic areas you see the echogenic areas. So you see an echogenic nerve with hypoechoic fascicles inside it. Nerve pathologies can be traumatic, entrapments, infective or inflammatory, tumor and tumor-like lesions, and then you have some other miscellaneous pathologies like a dynamic nerve entrapment or a dynamic neuropathy. So here you see, this is the median nerve, normal pattern. Now if you see, the nerve is becoming bulky and there are anechoic areas between, right? So I'll again try to play this. Okay, not able to. So again, so if you see, the nerve is now becoming bulky, and now if you see, there is an anechoic area, especially here. This was a partial nerve transaction of the median nerve secondary to injury. So this is how you will see the change in caliber. If you see a hypoechoic nerve, it's edematous. But if you see a complete anechoic area, it means that the nerve fibers are torn in that region. Okay. So any nerve injury, there are two classifications. This is an older classification, which is neuropraxia, which is the lowest form of injury, and then you have neurotomesis, which is the highest form of injury. But now what we use is a Sunderland classification, where you have grades 1 to 5, and then there is another grade 6, which is nothing but a mixed injury. So grades 1 to 5, just remember that muscle denervation changes are not present in grade 1. So if you see an edema in the nerve but no muscle denervation changes, that's grade 1 injury. If you see muscle denervation changes, that's grade 2 and 3 injury. Up to 3, it is still okay, the prognosis is still okay. But when it goes to grade 4, the prognosis becomes poor. What happens in grade 4 is neuroma in continuity. So basically you will see a hypoechoic area on ultrasound with disruption of nerve fibers, which is neuroma in continuity. Grade 5 is an end neuroma which develops after complete transaction and retraction of the nerve ends. So whenever there is a complete tear of the nerve and the nerve ends go wide apart, they cannot join back together, and it results in development of an end neuroma. And then grade 6 is a mixed injury. So this is just to show you that from the level of grade 4, you have a poor to no recovery, which means that these patients will require a nerve repair or a nerve grafting. So here, you can see that this was a median nerve injury, and we have imaged the patient after 4 months. And what you see, these echogenic linear structures, okay? So ideally what you do, you trace the nerve in short axis. Once you see the nerve, once you see the pathology in the nerve, you make the nerve in long axis. So if you can trace the entire hypoechoic fascicles in length, you are sure that you are looking at the nerve properly in long axis. So here you can see that there is a disruption. So here also, if you appreciate, there is a disruption of the nerve fibers. 1-2 nerve fibers are still appearing continuous, but otherwise there is a disruption of the nerve fiber, and there is a lesion that is formed along the nerve. This is a neuroma in continuity. Why continuity? Because the neuroma is still trying to bridge the two tone ends of the nerve. So it is neuroma in continuity. Again, on axial, if you see at the level of the neuroma, you cannot identify the fascicular pattern. So no longer the fascicular pattern is visible. It appears like a tumor. Whenever you see this kind of a picture, wherever there is a nerve injury, the second thing you have to do is look at the muscles. Okay, so here you can see this is the thenar eminence on the right side where the nerve injury had happened, and this is the thenar eminence of the patient on the left side. So you can appreciate that the thenar eminence is decreased in thickness. There is atrophy of the muscles on the right side as compared to the left, and there is a lot of fatty infiltration in the thenar eminence muscles, right? So this is the second thing. So this is a direct way where we saw the lesion first, then we went on to look at the muscles to see if there are any denervation changes. Second example, where you can see that the superficial nerve fibers of the median nerve at the site of injury are intact. So it was a partial nerve injury. So the superficial fibers were intact, but the deeper fibers, there is a lesion over here, right? So you can appreciate the superficial fiber is intact, and then the deeper fibers had a lesion over here, and this was, so you can see this fiber just disappears after here, right? So this lowermost fiber. So this was again a neuroma in continuity, but not involving the entire median nerve, right? Third example, this is something which is important to understand. So this patient had a cut injury, but luckily the cut did not cross the flexor retinaculum. So it was a very superficial cut injury. So what happened? The patient landed up with a neuroma in continuity of the palmar cutaneous branch of the median nerve. But since the cut did not cross or did not go deeper to the flexor retinaculum, the median nerve was intact. So the median nerve was normal, but instead there was a neuroma in the palmar cutaneous branch of the median nerve. So depending upon the depth of injury, this is how which nerve gets involved is something that will come into picture. Another patient, this was the posterior cutaneous nerve in the arm, and you can see this is the area of injury. So there is scarring, there is some residual hematoma in this region, and you can see there is a bulbous end over here. So up to here the nerve fibers are intact, and then there is a bulbous end in the nerve, and this is the end neuroma. End neuroma is a higher form of injury. It is neurotomesis or a grade 5 injury. And these patients, the other end of the nerve actually could not be well appreciated in this entire scarring. So these patients would require a graft where they will put a graft and bridge the two gaps of the nerve after removing this neuroma. Okay, so this is end neuroma. Now coming to entrapment syndrome. So entrapment is a structural abnormal. Entrapment happens because of a structural abnormality, and it can cause either compression of the nerve or traction. So if there is a fibrosis or scarring, it will cause traction of the nerve, or it is just displacing the nerve. Now the common locations of entrapment is the fibro-osseous tunnel, like the carpal tunnel or the cubital tunnel. Anatomic variations like ligament of Struders, compression by mass lesions or ganglion cyst, and then you have iatrogenic, where the nerve gets entrapped in the soft tissue adjacent to surgery. And the example that we've already discussed is the radial nerve, where it can get entrapped in the spiral groove following a fracture or following a fracture fixation. So carpal tunnel is the most common entrapment syndrome, and it can happen either with there is a decrease in the size of the tunnel because of a thickened retinaculum or bony spur, or there is increase in the content of the tunnel. So either ways we are decreasing the space inside the tunnel, okay, and it can, some patients you will have carpal tunnel without any of these. So you will not find any cause for the carpal tunnel, but the patient still has carpal tunnel. That is an idiopathic or overuse related, where they use a lot of wrist during their normal day-to-day work lifestyle. Carpal tunnel is not a radiological diagnosis. The surgeon already knows that patient has a carpal tunnel. Okay, so it is on the clinical symptoms and EMG NCD studies. Then why do we do imaging in carpal tunnel? One is if the clinical suspicion is high and the NCD is negative. Secondly, if the surgeon is suspecting that the carpal tunnel is because of the lesion inside the carpal tunnel. So if there is a carpal tunnel syndrome because of tenosynovitis or because of a mass lesion inside the carpal tunnel, then you want to image the carpal tunnel to identify the cause for the carpal tunnel syndrome. And the next thing is median nerve hydrodissection, which we do in patients, in idiopathic patients. So where you don't know the cause of carpal tunnel syndrome, so there is probably some scarring around the median nerve, and what you do is you do ultrasound guided hydrodissection, where you inject fluid all around the nerve and just separate the nerve from its adhesions. So here you can see that in the distal part of the carpal tunnel, the nerve is very thin in caliber. It's very small, and here you see that the nerve is in the proximal part, the nerve has become slightly bulky. If you look in the long axis of the nerve, see the nerve is becoming thinner and thinner within the carpal tunnel, and proximal to the carpal tunnel, the nerve is more than double the size, right? So this is the criteria that we use. So normally we take it up to 9 to 11 or even 12 millimeters square. We draw the cross section area with the hand, okay. More than 15 is abnormal, but if it is more than 14 is abnormal, but if it is more than 15, then it's considered as a more severe form of carpal tunnel syndrome and requires a release or a surgical intervention. However, rather than using this criteria, a better criteria is where you compare the nerve caliber at two levels. So as I told you, one is you look at the cross-section area within the carpal tunnel, and the other is you look at the cross-section area at the level of the pronator quadratus. And if the difference between the cross-section area at these two levels is more than 2 millimeters square, it means that there is carpal tunnel syndrome. Okay. Another indirect or a secondary sign of carpal tunnel is where we've seen the palmar retinaculum, which connects the scaphoid to the pisiformis, right? So this is how it goes. Now, if the palmar retinaculum, if there is increase in the pressure of the carpal tunnel, what will happen? The palmar retinaculum is going to go upwards or become more superficial. And if this length, vertical length, is more than 2 millimeters, it means that there is a palmar bowing, which in turn means that there is increased pressure in the carpal tunnel, and it is causing mass effect on the median nerve and carpal tunnel syndrome. Okay, so this is a nice secondary sign. This is the direct thing that you have to do, and this is another secondary sign to pick up carpal tunnel syndrome. Another patient where you can see that this was the median nerve. This is a ganglion cyst within the carpal tunnel. The nerve was getting displaced superficially. The tendons are going deeper to the ganglion cyst, and this was causing median nerve symptoms in the patient. Now let's come to the posterior interosseous nerve. So I've already told you the common site of entrapment of the PIN nerve is the arcade of Frosse, between the superficial and deep heads of supinator muscle. And another thing what I told you is you can compare the PIN nerve with the superficial radial nerve. The two of them are similar in caliber. If the PIN appears more bulkier or more edematous, it means that there is a PIN syndrome. So this is, you can see, this is a slightly bulky and edematous PIN nerve, both in short axis and long axis, in the arcade of Frosse. And another patient where you can see that there was a lesion. There was a soft tissue lesion which was anterior to the radiocapitellar joint. So this is capitellum, this is the head of the radius. It was located anterior to the radiocapitellar joint, and you can see it was causing, this is the superficial radial nerve. This lesion was extending into the level of the arcade of Frosse, and you can see this is the superficial radial nerve, and look at the PIN nerve. You can see that the PIN nerve is obviously double the size of the superficial radial nerve, and this patient had symptoms of PIN syndrome. Okay. Third example where I told you that when there is a mid-shaft fracture of the humerus and there is a plate fixation with screws that has been done for fracture fixation. And you can see this is the capitellum. So the plate is placed posteriorly. You can also see the acromion process here. So this is the posterior aspect of the arm. We don't place it anteriorly because you have the brachial artery, you have the median nerve, many important structures anteriorly. So what happens is they have to put the plate posteriorly. And in such cases, some patients can develop gradual wrist drop. So you can see this is the metallic implant. You see there's some artifacts. So this is the metallic implant in the midshaft of humerus, and look at the nerve next to the implant. It's bulky. Each of the fascicle is appearing more bulky and edematous. So what has happened is, because of the implant slightly protruding out, there was scarring adjacent to the implant, and this entrapped the radial nerve. Because of the scarring entrapped the radial nerve, and it developed radial nerve symptoms and subsequent wrist drop. So this particular patient you will not be able to diagnose on an MRI because the nerve is very close to the implant, and it is not possible to look at the nerve with the metallic artifacts. Okay. Another way to identify that there is a radial nerve injury, look at the muscle. So you see this is the normal triceps muscle on the left side, whereas look at the triceps muscle on the right side. It's less than 1/3 the thickness of what it is on the left side. which means that triceps is undergoing muscle atrophy and muscle fatty infiltration, which in turn means that there is a radial nerve injury. Okay. This nerve we've not discussed, but another one is a suprascapular nerve entrapment. So this is nothing but a paralabral cyst. This is the spinoclenoid notch of the glenoid. Here is the labrum. There is a labral tear, and which has caused a posterior paralabral cyst extending into the notch, and this is the neurovascular bundle. So the bundle can get compressed in the notch. Okay, this is on the MRI, so you can see a labral tear with a paralabral cyst, and then there is a neurovascular bundle which is getting compressed. You can appreciate there is edema. There is edema in the infraspinatus muscle, which means that there is compression of the suprascapular nerve in the notch because of this edema in the infraspinatus muscle. So what you can do is you can just put in a needle in the paralabral cyst, aspirate it out or fenestrate it. So you can just track the needle down into the cyst, aspirate it out or fenestrate it and get rid of the cyst. Infections are not very common, but they can happen in the peripheral nerves, which can be bacterial, tubercular, leprosy, but leprosy is the most common one. And sometimes you may require a biopsy to confirm the diagnosis of the infection. So this patient had bilateral ulnar nerve which were bulky. Some vascularity was there within the nerve, and this patient was later diagnosed as leprosy. Another patient where you can see the nerve is appearing like a vessel. It is very tortuous, it is very thickened and has a lot of vascularity inside it. This was a diagnosed patient of leprosy. Tumor and tumor-like lesions. So this is a tumor, okay, where you can see there is increased vascularity. This is the nerve, superficial to it, okay, and deep to it. So it's kind of splitting the nerve, and there is a fat. So this fascicular sign helps you to diagnose that this is a schwannoma or a nerve sheath tumor. Okay, so here you can see this is the MRI of the patient where anteriorly you can see the nerve. You can see the lesion separate from the nerve because schwannoma arises from the nerve sheath, not from the nerve itself, right? So the nerve gets displaced and you can see this fascicular sign or the fat-like edges, the edges which have appear bright, and this is nothing but a schwannoma. Another where you can see that this is a lesion which is involving the nerve. The nerve itself is getting thickened, right? So this was a neurofibroma which was involving the nerve fibers. Another patient where you can see that it's a very mixed solid cystic lesion along the ulnar nerve, and this turned out to be a malignant peripheral nerve sheath tumor which was present almost just proximal to the level of the Guyan's canal. Okay, and you can see this patient had a classical hypothenar muscle atrophy because the ulnar nerve had the tumor. This is a very classical example. If you see this picture, there is only one diagnosis to it. So you can see the median nerve is very much increased in size. The fascicles are bulky, but more importantly, there is a lot of echogenicity and fat between these nerve fascicles. And this is a fibrolipomatous hamartoma of the nerve, very well seen even on a MRI, very well appreciated even on an ultrasound. Okay. Sometimes you can get intraneural ganglion cysts, or ganglion cysts that extend into the nerve as well. So this is an intraneural ganglion cyst in the ulnar nerve. It's like any cystic lesion, just that it will be present within the nerve. And the last thing is ulnar nerve dislocation. I've told something called as snapping ulnar nerve or ulnar nerve dislocation. And then there is another entity called as the snapping triceps. Snapping triceps is where the medial head of biceps enters into the cubital tunnel and, medial head of triceps enters into the cubital tunnel and displaces the nerve along with itself. So let's just look at a couple of examples. So here you can see as the patient is going to flex his hand, the nerve just pops out, right? So it's dislocating anteriorly. So again, it's posterior, and now as the patient is flexing the hand, it just crosses the level of the medial epicondyle and goes anterior. So this is nothing but ulnar nerve dislocation. This structure that you can see coming in the image, this is the medial head of triceps. But the medial head of triceps is not crossing the level of the medial epicondyte. So it is not a snapping triceps. It is just that the ulnar nerve is dislocating, which can be because of absent Osborn ligament, a weakened or a lax Osborn ligament. Another patient where you can see not only the ulnar nerve has dislocated out, but even the medial head of triceps is going along with it. So this is a snapping triceps syndrome where the problem is not with the ligament, the problem is the medial head of triceps on flexion is going anteriorly and pushing the ulnar nerve along with it. So here you need to treat the triceps and not the ligament. Okay, so this is the snapping triceps syndrome. So take home message, ultrasound is a very good modality for peripheral nerve pathologies and therapeutic interventions. Like I said, you can do hydrodissections, you can do paraneural cyst fenestrations, and then obviously you have dynamic ultrasound, particularly for the snapping ulnar nerve, which is very difficult to identify on an MRI, because MRI we always do in extension. It is very easy to scan the entire nerve of the entire upper limb. MRI will take a much longer time, and then always compare with the opposite side. Compare the nerve and compare the muscles that are being supplied by that nerve. Thank you so much.